When you picture a sterile environment, you probably imagine like a microchip manufacturing plant.
Right, yeah, like people in full hazmat suits.
Exactly.
Oh.
We're talking smooth, non-porous surfaces, sealed airlocks, everything wiped down with industrial bleach.
Yeah.
It's an environment that's engineered from the ground up to be, well, completely devoid of life.
Yeah, it is a true clean room. I mean, there are no variables, there's no unpredictable biology, just cold, hard surfaces.
Right. But then you take that expectation of absolute pristine sterility and you try to apply it to the human body.
Which is basically the exact opposite of a clean room.
It really is, and specifically applying it to the human surgical field. Suddenly you aren't trying to sterilize a smooth sheet of metal in a, temperature-controlled room.
No, definitely not.
You're dealing with folds, moisture, and millions of microscopic organisms that are very happy exactly where they are.
Right. The environment is biologically dense. It's highly textured. I mean, it is an ecosystem that has spent an entire lifetime establishing itself.
And nowhere is that ecosystem more complex than in pelvic and vaginal surgery. So, welcome to today's Deep Dives. We are on a mission to explore the meticulous, almost choreographed scientific process that surgeons use to maintain a sterile field in one of the most microbiologically populated areas of the entire human body.
It's a huge challenge.
It is. The central puzzle we're solving today is this. How is sterile field prep maintained along the introitus and the anterior wall to prevent introducing vaginal flora into the submucosal space?
Yeah, which is a lot of medical terminology for a very physical problem.
Right. Basically, how do you create a safe, sterile entry point and then cut deep into the tissue without dragging a massive payload of surface bacteria down with you?
It really is one of the greatest biomechanical hurdles in modern medicine, because you are attempting to breach a highly populated surface to reach a vulnerable, sterile interior, and you have to do it without any cross-contamination.
So to figure out how surgeons actually pull this off, we're looking at a really fascinating stack of sources today. We've got surgical step-by-step guides, including the AORN guidelines and strict protocols from Parkview Health.
Some really detailed stuff in there.
Yeah, the step-by-step is intense. We're also pulling from some very recent randomized controlled trials on antiseptics and a really eye-opening study from the Mayo Clinic on the postoperative microbiome that really changes the way you look at recovery.
It absolutely does.
So if you are prepping for a medical procedure yourself, or maybe you're studying the surgical field, or you're just insanely curious about how medicine solves these impossible biological puzzles, this dive is going to fundamentally change how you view surgical sterility.
I completely agree.
Okay, so let's unpack this. We have to start with the very first step before a knife even enters the room. Right, the chemical wipe down.
Yeah, the chemical prep really sets the stage. I mean, before a surgeon even thinks about making an incision on the anterior wall, that entire surface area has to be chemically neutralized. But the wild thing is, for decades, the standard chemical the medical field relied on was actually fighting a losing battle against human biology.
Wait, if the standard chemical was failing, what was it? Because when I picture surgical prep, I just picture like that classic brown liquid painted all over the patient's skin.
Yeah, you're picturing povidone iodine.
Oh, betadine.
Exactly. Commonly known as betadine, it has been the FDA-approved standard for vaginal preparation for a very long time.
Okay.
But there's a massive biological catch here, which was brilliantly highlighted in a trial by Lackey and colleagues. You see, the normal healthy environment of the vagina is highly acidic. We're talking a pH of about 3.8 to 4.5.
Which, if I remember my basic biology, is actually great for everyday health, right?
Yeah.
Like, acid keeps bad bacteria and yeast in check.
It does. It's a great defense mechanism.
Yeah.
But the catch is that this exact same acidic milieu actively diminishes the disinfecting properties of iodine.
Wait, really?
Yeah, the chemistry just doesn't work optimally in that environment. So the iodine is essentially deactivated by the very ecosystem it's trying to sterilize.
That seems like a massive oversight. I mean, the FDA-approved gold standard is failing right out of the gate simply because of the local pH.
It's a huge problem, yeah.
So if iodine is being neutralized by the body's natural acid, what are surgeons actually using instead to get the area clean?
Well, they are increasingly turning to an off-label solution called chlorhexidine gluconate.
Oh, CHG.
Right, CHG.
Okay, but wait, I've seen CHG wipes at the hospital. Doesn't the manufacturer's label on that stuff specifically warn against using it in sensitive areas?
It does. If you read the manufacturer's instructions for CHG, it strictly warns against using it in the genital area.
Because it's too harsh.
Yeah, it can cause severe tissue irritation and desquamation,
Desquamation.
which is essentially a peeling or sloughing off of the skin.
Oh, wow. So the bottle literally says, do not use here, but surgeons are using it anyway.
They are, because the clinical data overriding that warning is staggering. I mean, the American College of Obstetricians and Gynecologists, or ACOG, actually supports its use based on massive amounts of evidence.
Okay, so the data must be pretty compelling then.
It is. There was a recent meta-analysis that looked at almost 5,000 women, 4,936 women to be exact, across 12 different randomized controlled trials.
That's a huge sample size.
Yeah, and it showed that CHG is vastly superior to iodine for preventing surgical site infections. And here is the key. When used in specific concentrations, usually a 4% solution with low alcohol content, it is actually very well tolerated by the tissue.
I want to understand just how much better it is, though. Because if you're going off-label and risking, skin peeling, the payoff has to be huge.
Oh, the payoff is undeniable. Take the Marino trial, for example. This study looked at patients undergoing laparoscopic hysterectomies.
Okay.
They cultured the surgical site after the chemical prep was finished, but before the surgeon made the first incision.
So right before they start cutting.
Exactly. With the standard iodine, there was massive bacterial growth remaining in 93.8% of the cultures.
Wait, almost 94%. So the iodine essentially left the bacteria completely intact. That's barely doing anything at all.
Right. It really highlights the pH problem we discussed, but when they used a 2% CHG solution, the bacterial growth dropped to 47.4%.
Okay, that's a lot better.
And when they bumped it up to the 4% CHG solution, bacterial growth plummeted to just 20%.
Wow, that is a massive drop.
It is. And what's really interesting is that stark difference was most pronounced in obese patients who often have a higher baseline risk for surgical site infections to begin with.
Oh, interesting.
Yeah, the 4% CHG was really the only agent that reliably knocked the bacterial load down to a safe level across the board.
But the chemical can only do so much on its own, right?
Yeah.
Like you can't just splash it on and hope for the best.
Definitely not.
Because looking at the protocols from AOR and Parkview Health, the actual physical choreography of how they apply this 4% CHG is incredibly strict.
Yeah, the application technique is just as important as the chemical itself. It's a very specific top-down motion. They start at the pubic area and sweep down across the vulva and perineum.
Yeah, I was reading through those steps, and it really struck me. It's essentially like mopping a highly contaminated floor.
That's a great way to think about it.
Right, because you can use the most expensive hospital-grade chemicals in the world, but if you don't use a single unified directional sweep, you're just dragging the dirt back over the spots you just cleaned.
Exactly. That directional flow is the entire point. You're always moving from the cleanest area to the dirtiest area.
Right, because according to the Parkview protocol, once that prep sponge passes the anus, it goes straight in the trash.
Yep.
It never touches the patient again. They use fresh sponges for the inner thighs, wiping outward. Then they use entirely new, fresh sponges to aggressively scrub the vaginal vault and cervix in a circular motion.
Every single pass is designed to mechanically dislodge bacteria, pulling it away from the surgical site, while simultaneously applying that 4% CHG to neutralize whatever microscopic flora is left behind.
There was one detail in that Parkview protocol that I couldn't quite wrap my head around at first, but it goes back to what you said earlier about the skin peeling.
Oh, the drying step.
Yes. The very last step of this incredibly wet chemical scrub is to take a completely dry sponge stick, insert it into the vagina, and just absorb any excess fluid that pooled up. Why go through all the trouble of applying the chemical just to soak it back up?
Well, that is a crucial safety step to prevent the very irritation the manufacturer warns about.
Oh, so it stops the chemical burns.
Exactly. Chemical burns and skin desquamation typically happen if the CHG is allowed to pool in the deep crevices of the tissue and just sit there for the duration of a multi-hour surgery.
That makes sense. It's just too concentrated for too long.
Right. So by inserting that dry sponge, the surgical team wicks away the heavy excess liquid. This leaves behind just a thin, active, microscopic film of the antiseptic. It prevents the chemical burns while perfectly maintaining the sterile barrier.
Okay, so we have the floor chemically mopped. The immediate area is as sterile as it can possibly be. But that brings us to the next massive hurdle. Because even if you completely sterilize the immediate surgical site, you still have a highly active, heavily populated bacterial reservoir right next door.
Ah, yes, the lower GI tract.
As the anus.
Notes.
During a long pelvic surgery, you have to ensure that fecal flora doesn't migrate up and completely ruin that pristine field you just spent all this time prepping. So how do surgeons physically block that off?
Well, they have to build physical blockades. In certain procedures, like obstetric fistula surgeries, which repair severe tearing between the vagina and the bladder or rectum, mechanical retraction is standard.
Okay.
The surgeons will literally suture the labia out of the way, pinning the tissue to the outer skin.
Wait, so they sew the folds back just to keep them from falling into the workspace?
Yes, it improves visual access, sure, but it also physically anchors the tissue down so it can't flop back into the sterile field and bring unsterilized skin flora with it.
That makes sense.
And then, of course, the anus is completely covered.
Okay, covering it makes total sense. But then I was looking at the Nanthaprawat randomized trial, and they tested a technique that sounded borderline medieval.
The purse string suture.
Yes, it's called the anal purse string suture. From what I understand, they take a silk 3/0 thread and, wait, do they actually sew the anatomy shut?
They do.
That sounds like it would cause nerve damage or, like, severe post-op complications. Is the risk of contamination really so high that they need to sew the GI tract closed?
An anal purse string suture is exactly what it sounds like, and you're right, it is an intense concept. The surgeon stitches a continuous thread in a circle around the anal sphincter. And before they begin the main vaginal surgery, they pull that thread tight like the drawstrings on a literal purse. It ties the anus completely shut for the duration of the operation.
That is wild. Just structurally clamping off the GI tract.
Mhm.
But going back to my question, does doing something that extreme actually work better than just covering it up?
Well, here is where the clinical data provides a really surprising piece of nuance, because mechanically it makes total sense. If you want to stop a leak, you tie off the source.
Right.
But the Nanthaprawat trial actually found no statistical difference in gross or microbiologic contamination between the patients who had the purse string suture and those who just had a standard covering.
Wait, really? Tying it completely shut offered no extra protection at all?
None at all. The rate of new contamination creeping into the surgical field was statistically the same.
Wow.
Now, to address your concern about damage, the trial did prove the suture was harmless. It didn't cause permanent damage or severe pain, but it was proven to be clinically unnecessary.
That's fascinating.
Yeah, the standard physical draping, combined with the meticulous chemical prep we just talked about, was just as effective as physically sewing the anatomy shut.
You know, if you're listening to this, you'd probably assume that sewing a contamination source shut is the absolute safest bet. It's such a great example of how much trial and error goes into surgery. Just because a physical barrier makes logical sense in our heads doesn't mean the microscopic reality will actually back it up.
Exactly. And we see that same paradox with adhesive plastic incise drapes.
Oh, the clear plastic sheets, they stick directly onto the skin.
Yes. The idea is that you stick the plastic down and the surgeon cuts right through the plastic into the skin.
Okay, theoretically trapping all the surface bacteria beneath the adhesive.
Right, theoretically. But according to the World Health Organization's guidelines for safe surgery, those adhesive drapes might actually increase bacterial recolonization.
Wait, how is that possible? If the plastic is perfectly sealed to the skin, how are the bacteria multiplying?
It creates a greenhouse effect.
A greenhouse effect.
Yeah, the plastic traps the natural moisture and body heat from the skin. It causes the pores to open up, and the bacteria that were hiding deep inside the sweat glands, the ones that actually survived the chemical prep, they rise to the surface and multiply rapidly in that warm, trapped moisture.
Oh, yuck.
Right. So what seems like a bulletproof physical barrier actually creates a breeding ground right next to the incision.
That is, wow. Okay, so let's set the scene here. The patient has been meticulously prepped with 4% CHG.
Right.
The excess fluid was dried up so there are no chemical burns. The physical drapes are perfectly placed, but, without creating that plastic greenhouse effect.
Exactly.
So the borders are completely secure. Now we arrive at the main event, getting inside.
The surgical breach.
Right. Let's say a surgeon is doing an anterior repair,
Yeah.
fixing a prolapse on the front wall of the vagina. How does a surgeon actually make that first cut along the introitus in the anterior wall without taking whatever surface bacteria is left and pushing it directly into the deep submucosal space?
It's tricky.
Right, because if I take a knife and press it into a contaminated surface, I'm just dragging the dirt downward as I cut. How do they avoid that?
That is the exact biomechanical challenge. You see, the epithelium, which is the surface layer, is the contaminated zone. The fibromuscular layer beneath it is the sterile zone.
Yeah.
If you just press a sharp blade straight down through both, you risk dragging the contaminated epithelium right into the deep tissue. To prevent this, surgeons use a brilliant technique called hydrodissection.
Right, hydrodissection. I was reading about this in the SUPUIU cadaver lab guides. It says they inject a mixture of normal saline and a vasoconstrictor, something like adrenaline, epinephrine, or vasopressin, directly beneath the vaginal mucosa.
Yep, that's the one.
But they do this before they make a single cut. Trying to visualize this. Are they basically injecting a localized water balloon under the skin? How does injecting fluid prevent an infection?
Think of it exactly like a localized water balloon. When the surgeon injects that fluid into the submucosal space, it forcefully raises what we call bullae.
Bullae, like blisters.
Yes, essentially controlled, fluid-filled blisters. The mechanical hydrostatic pressure of that fluid physically lifts the epithelial, flaps off the underlying fibromuscular attachments.
Wait, so the liquid is actually doing the separating?
Exactly.
It forces the layers of tissue apart from the inside out before the scalpel even touches the patient.
It creates a vast, fluid-filled buffer zone. The surface layer is now floating on a cushion of liquid, completely separated from the deep layer. But the fluid isn't just water. It contains that vasoconstrictor you mentioned.
Oh, the adrenaline or epinephrine? What does that do?
Well, the adrenaline causes all the local blood vessels to clamp down instantly. This results in a phenomenon called blinching. The tissue literally turns stark white because the blood has been squeezed out of the capillaries.
Okay, so the blood vessels are clamped closed, which means there is minimal bleeding. So the surgeon is now staring at a stark, white, totally clear, avascular plane.
Right. And because that plane is separated by the fluid cushion, the surgeon doesn't have to make a massive dragging incision to get in. They can make a very small tunneled incision.
Oh, okay.
The cadaver lab guides actually refer to it as a kangaroo pouch.
A kangaroo pouch. I love that visual. Just a small, isolated pocket.
Exactly. It's a tiny entry point. And once the surgeon is inside that pouch, because the fluid has already done the hard work of separating the tissue, they don't need to sharply slice their way through. They can mostly rely on blunt dissection.
Blunt dissection meaning like using their fingers or smooth instruments instead of a blade.
Yes, exactly. They gently push the tissue apart along that fluid plane. It separates naturally along the path of least resistance.
Wow.
This drastically reduces the chance of tearing the tissue, which means they aren't dragging that contaminated surface mucosa down into the deep fascial layers.
It is absolute genius. I mean, they're using mechanical fluid pressure as a literal tool for infection control.
It really is.
They use a water balloon to pry the door open from the inside, so when they step through, they aren't trekking mud into the house. It perfectly preserves the sterile field during the breach.
Yeah, it is a masterclass in combining pharmacology, the adrenaline with physics, the hydrostatic pressure to basically outsmart biology.
Okay, so the surgery is a success. The field remains sterile. The kangaroo pouch kept the submucosal space completely pristine, the prolapse is repaired, the sutures are in, the surgical team packs up, and the patient goes to recovery. But what happens to the patient's local biological ecosystem after the surgical team leaves? Because we basically just went and clear-cut a forest, right?
We absolutely did. We removed the predators, sure, but we also removed the roots holding the soil together. And that brings us to a highly complex, often overlooked consequence of all this meticulous preparation.
The microbiome paradox.
Yes, the microbiome paradox.
This is where that recent Mayo Clinic study by Dr. Marina Walther-Antonio and Dr. John Aquino really blew my mind. They looked specifically at the microbiome of postmenopausal women undergoing these exact types of surgeries, vaginal hysterectomies and pelvic organ prolapse repairs.
And the findings in that study really highlight the double-edged sword of surgical sterility.
How so?
Well, the very acts required to prevent an immediate catastrophic surgical site infection, the broad-spectrum prophylactic antibiotics, the aggressive 4% chemical scrubs, the mechanical wiping, they completely devastate the natural vaginal and urinary microbiomes.
Right, it makes sense. We just talked about how effective CHG is at wiping out 80 to 90% of the bacteria, but that includes the good bacteria too.
Exactly. The study showed that these patients experience massive drops in microbial diversity immediately following surgery. Specifically, there is a severe depletion of a bacterial species called lactobacillus.
Lactobacillus, that's the good stuff, right? Like the protective guards of the local ecosystem.
They are the primary defenders. Lactobacillus is what actually produces that highly acidic pH of 3.8 to 4.5 that we talked about at the very beginning.
Okay, full circle.
Right. That acid creates an environment that is naturally hostile to pathogens, but the surgical prep completely wipes them out.
And when the guards are gone, the bad actors move in.
The Mayo Clinic researchers found exactly that. Patients who ended up with lower levels of protective lactobacillus post-surgery also had skyrocketing levels of inflammatory bacteria.
But what kind?
Two specifically, Prevotella and Gardnerella. And here is the critical clinical link that affects the patient's lived experience. Those patients with high Prevotella and Gardnerella were at a significantly higher risk of developing urinary tract infections, or UTIs, during their recovery.
And a UTI after major pelvic surgery isn't just a minor inconvenience. I mean, you're dealing with internal sutures, swelling, healing tissue, and now a secondary infection on top of it.
Yeah, the biological stakes are very high. It perfectly illustrates the core tension of this entire field. Surgical prep requires absolute, uncompromising devastation of the local flora.
Because if you don't do it, the patient gets a surgical site infection.
Exactly, which can be rapidly life-threatening. But that exact same necessary devastation leaves the body's natural defenses completely down, making the patient highly vulnerable to opportunistic infections in the weeks following the surgery.
So what does this all mean? If you're listening, it means recognizing that surgery is never just a mechanical act of carpentry. It's an incredibly precarious biological balancing act.
It really is.
Surgeons are fighting chemical pH levels, they're orchestrating physical sweep protocols, utilizing mechanical fluid cushion dissections to breach the introitus safely, and altering microscopic ecosystems, all at the exact same time.
Every single step matters.
Every step, from the dry sponge wicking away excess chlorhexidine to the adrenaline blenching the tissue, it's all designed to outsmart an invisible enemy.
It really forces us to realize that a sterile field isn't a natural state. It is a highly artificial, temporary zone of safety. It requires massive chemical and physical force to maintain, and there is a very real biological cost to creating it.
Which brings me to a final thought, building on that vulnerability post-surgery. We know from the Mayo Clinic study that wiping out the microbiome is absolutely necessary for the surgery to succeed, but keeping it wiped out is harmful for the patient's recovery.
Right.
So what if the future of surgical prep isn't just about applying antiseptics? If we have to wipe out the microbiome to save the patient, how do we help them rebuild it?
You're talking about proactively repopulating the area.
Yes. What if, 10 years from now, the very final step of a vaginal surgery isn't just closing the incision? What if the final step involves applying a surgical probiotic?
Oh, wow.
Imagine the surgeon intentionally seeding that healing incision with a specialized designer strain of lactobacillus. They could theoretically rebuild a biological shield against UTIs and other pathogens before the patient even leaves the operating room.
That is, it would be like proactively replanting the forest immediately after the clear cutting so the invasive weeds don't have a chance to take over. It's a fascinating area for future research.
Until that becomes a reality, we rely on the meticulous step-by-step choreography of the prep. Thanks for joining us on this deep dive. Keep questioning, keep learning, and the next time you think of a pristine surgical field, remember, it's not an empty room, it's a rainforest floor, perfectly managed, 1 millimeter at a time.